Hi, everyone. Good morning. Good afternoon. We see that folks are coming into the webinar now. We'll give just a moment as people are joining. Thanks very much for joining today. You are welcome to introduce yourself in the chat if you'd like to, and we will get started in just a moment. Wonderful. Well, it seems like we've had quite a few people join, so thanks very much. Today, we are pleased to have our third webinar in our series of ZIP webinars. We are pleased today to be talking about integration in immunization programs and humanitarian contexts. So we'll have some great speakers today. We have some examples from our REACH project, from South Sudan and Cameroon, as well as our Gavi colleagues speaking. So we are very excited for that. I will first go over a few housekeeping items. So what we'll do is we will put the housekeeping items up in French right now so our French colleagues can see, but I'll go ahead and read them in English to you. So we do have interpretation available in both English and French. To access it, you will click on the globe icon at the bottom of your Zoom window and select the French language if you'd like French translation. The presentations will be in English, but translated over to French. As I said, please feel free to introduce yourself in the chat, your name, organization, and country. We love to know who's joining us today. Also, during the webinar, we'll have a few quick polls. So when the time comes, you'll be notified and a panel will appear. Of course, we encourage you to participate and select the answers. We also will have a Q&A session at the end of the presentation. So please use the Q&A button at the bottom of your screen, and we will be able to answer questions through that. Dr. Falake, our moderator, will lead us through questions at the end. So please feel free to send those over. And also, you're welcome to use emojis and the raise your hand buttons during the webinar to react as participants are saying things. So again, thanks so much for joining us. And now I am pleased to introduce our moderator. Great. Oh, first, I'll actually share our agenda. I've said this a little bit, but we will have our introduction. Then we will have our expert presentation. So first, we'll hear about Gavi's commitment to integration in humanitarian settings. We'll then see a great example of integrated services in Cameroon, and then hear from our REACH colleagues talking about their experience across many countries overall, and then also a deep dive into an example in South Sudan. And we'll close with questions and answers and closing remarks. Thanks very much. So great. Now I am pleased to introduce our moderator, Dr. Falake Oleyinka. She is a highly respected leader in global immunization with more than 30 years of experience across global health. So Falake has worked across immunization, polio, maternal and child health, infectious diseases, and is widely known for her leadership in reaching zero dose and under-immunized children. So many of you may know her from her time as the immunization lead at USAID in Washington, D.C. We know her well from moderating the series of webinars. So we're grateful to have her back for a third time. And she now serves as a global health consultant supporting international organizations and philanthropies. She brings a lot of expertise in vaccine policy and strategic program design, especially in complex and diverse settings, which makes her a perfect guide for today's discussion. She has shaped some of the global immunization strategies through her roles on major advisory bodies like WHO SAGE and the IA 2030 Working Group. So we're very grateful to have her moderating today. So Dr. Falake, over to you. Thanks so much.
Brooke, thank you for such a lovely introduction. Let me welcome all our participants today. I am pleased to begin the webinar, which focuses on integration efforts to reach zero dose and under-immunized children in fragile, conflict-affected, and humanitarian settings, where we are seeing increases in numbers of unimmunized children. Conflicts and humanitarian crises have escalated to record levels and more than doubles in the last 5 years. Through the ZIP project and its partners, Gavi continues to reinforce its commitment to integrating immunization into existing service delivery, particularly in crisis contexts, also in alignment with the Immunization Agenda 2030. Fragile and conflict-affected humanitarian settings pose significant challenges for service delivery partners and the communities they support. Effective programs in these environments must demonstrate agility, resilience amidst persistent risks, difficult terrain, long distances, and limited infrastructure. Today, we'll hear from two partners, the Cameroon Baptist Convention Health Services and the International Rescue Committee's REACH team about their strategies, experiences, integrated immunization with other services in these settings. At this point, I'd like to welcome our excellent lineup of speakers today. You have on your screen Stéphane Dufis, the Senior Manager, Humanitarian Immunization Programs, ZIP at Gavi. Stéphane is an operations and program management specialist with 15 years of experience in strategic and operational roles. He has previously held significant positions such as regional advisor at USAID and West Africa regional representative at the Action Against Hunger. Welcome, Stéphane. Dr. Epie Njume is a technical coordinator and immunization expert for the Cameroon Baptist Convention Health Services Immunization Program in Cameroon. He has held various roles within CBC Health Services over the past decade. Alongside his clinical work, he has designed community programs and strategies to detect, diagnose, and manage chronic conditions. We're so excited to have you, Dr. Njume. Peter Mutanda is a healthcare quality improvement specialist with IRC and brings much experience in public health, healthcare management, and various technical roles in health programs. Peter has been in active healthcare service delivery and healthcare management for the past 20 years, starting and managing reproductive health clinics, maternal newborn, childcare hospitals, and health programs in emergency as well as stable settings. Welcome, Peter. And Dr. Muni Safi is the project coordinator for IRC Reach in South Sudan and is a medical professional with exceptional expertise in emergency response and disease outbreak management, bringing over 10 years of impactful experience in humanitarian health programming. And to wrap us up today, we're pleased to have Caroline Quijada, who is a board member with the core group and an independent consultant providing strategic advisory management and executive leadership support to organizations in global health. With more than 20 years of experience advancing reproductive, maternal, newborn, and child health, she is widely recognized for her expertise in private sector approaches and partnerships, design, navigating growth, and restructuring. We have such a stellar lineup today. I am really excited. First up, we have Stéphane Dufis, and I want to hand over to him. Just doing a quick check here now.
Yeah, thank you very much. Can you hear me? Yeah, it's fine?
Yes, very well. Thank you. Please go ahead, Stéphane.
All right. Thank you very much, Folake. And yeah, thank you everyone for joining today. I'll try to be brief so that we have more time for our wonderful lineup of presenters. So it's really encouraging to see such a strong turnout around integration in humanitarian immunization, which is such an important topic. I also want to take this opportunity briefly to sincerely thank Core Group for hosting this webinar and also for their continued role in supporting learning, documentation, as well as knowledge sharing across ZIP, but also the broader humanitarian immunization community. So thank you again. I think this kind of space is really exactly what is needed to move the conversation from concepts to practice. All right, so let me start by briefly situating ZIP and the partnerships that actually underpin this work. So ZIP was designed specifically to reach children living in conflict and crisis settings, places where routine immunization systems are disrupted, access is constrained, and government service delivery is often highly limited or just absent. So these include areas affected by active conflict, large-scale displacement, mobility across borders, and non-state armed, actor control. Over the past few years, ZIP has built a set of humanitarian partnerships that are really tailored to those contextual realities. Through partners such as IRC and CBCHS, and with the support of core group for the learning and the communication, ZIP has actually been able to reach over 3 million children with a first dose since December 2022, and about 1.5 million just last year. And I think what's important to emphasize today is not just the scale, but actually how this work has been delivered. Indeed, ZIP partners are not just delivering immunization in isolation. The delivery models are actually adapted to insecurity and mobility constraints, and coordination with other actors is absolutely essential. Because vaccination is often integrated with nutrition services, with basic primarily healthcare, with community outreach, and just broader humanitarian responses in the areas where ZIP is operational. And I think this is really where ZIP partners deserve real recognition, because integration is happening on the ground, and it's happening in a very pragmatic, context-specific way that are really crucial in some of the most challenging operating environments. And at the same time, I think we have to be honest, the needs remained significant, access remains fragile, and integration, although it is happening, it's happening very unevenly across context. But ZIP has demonstrated that integration is not only possible, but it's actually really necessary. So this brings me to why integration is actually so critical in those humanitarian settings. Because in this context, integration is not just a policy preference or a design choice. It's really often the only way services can really reach children at all. The communities that ZIP is designed to reach are not just underserved; they are missed for prolonged periods. They face compounded vulnerabilities such as conflict, displacement, food insecurity, weak or absent health services, as well as restricted movement. And expecting families in these settings to actually engage with fragmented vertical services is just unrealistic. And ZIP partners have shown that immunization works much better when it is integrated. When vaccination is delivered alongside nutrition screening, for instance, or primarily healthcare, or food assistance distributions, or other services that the communities prioritize, then uptake improves. And not just for vaccine, but across services more broadly. So integration is also fundamentally about trust. In conflict-affected settings, trust in institution, as we know, is really fragile. And ZIP partners have to build acceptance over time. And when they do so by really responding to the priorities that are identified by the communities. To do that, they use local staff that engage with community leaders, um, with focal points from the communities to really understand what is really important for them. And then they tailor the services in a way that align with with the community's reality, and vaccination is one of those components. And of course, beyond that, there are also very practical and operational cost benefits to integration. Integration reduces duplicative trips, it improves coordination, and also limits exposure to security risk by just reducing movement. It's just more cost efficient. Delivering multiple services through a single contact point allows partners to stretch limited resources further while maintaining quality in extreme constrained environments. So, in humanitarian context, I want to stress that integration is not just an added layer on top of immunization. It's actually a core condition for access, acceptance, efficiency, and safety. And if we can move to the next slide. So here I just want to flag that under Gavi 6.0, integration is explicitly embedded in the approach to strengthening health system and increasing equity in immunization. The strategy recognizes that reaching zero-dose unmissed communities requires linking immunization investment with broader primarily healthcare and working more intentionally with partners beyond vaccination. And I think in many ways, ZIP has been operationalizing this vision ahead of the policy by demonstrating how immunization can serve as an entry point for broader service delivery in fragile and humanitarian setting, rather than functioning as a purely vertical intervention. So looking ahead, I think the challenge is to make integration much more intentional, systematic, and supported through grand design, partnership models, coordination mechanisms, while making sure that we remain country-centric, but also very context-specific. And I think this is where the rest of today's webinar becomes especially important, because what will follow are practical, grounded example of what integration really looks like in reality. And I think those presentations will really help us to move from the why and the policy intent to really the how, including what works, what remains challenging, and what we still need to learn. So with that, I'll stop here. I'll hand back to you, Dr. Olainka, so that you can move us to the first country presentation. Thank you.
Stefan, thank you for such a wonderful overview here, setting the stage. So I'm going to invite all of you to take this poll that is on your screen. And just to warm us up a little bit, this question number 1, what are your top 2 priorities in delivering integrated services? Quelles sont vos 2 principales priorités en matière de prestations de services intégrés? So please take 30 seconds. I'm giving you 30 seconds to reflect some of your thoughts to this question on the screen. Top 2 key priorities in delivering integrated services. En français, quelles sont vos 2 principales priorités en matière de prestations de services intégrés? If you're just joining us, let me extend a warm welcome to you. We are taking the poll, which we will wrap up in the next 20 seconds. Please put your responses in the poll. I see some in the chat. I appreciate it very much. I hope you can put it in the poll as well. Thank you, Yusuf. Okay. Maybe we can take a look together at the responses. I hope you can see on your screen here, but what I can see here in terms of the results, we actually have top in terms of about 61% of the responses highlighted meeting community needs as one of the top two priorities. This was followed by increased uptake of services at 54% of the responses highlighted this. So that's really interesting, and I greatly acknowledge the focus on meeting the community needs. Another one that came up quite strongly, I would say at about 46%, is looking at the resource optimization, so the cost effectiveness. What are the resources and how really are we getting more value from money here? And then improved efficiencies came in at a fourth level here. Let me thank you all for sharing these quick reflections. Really, really wonderful to see. We're going to go on and Lisa, thank you for your comments in the chat. We're going to go on to the next speaker, who I have the pleasure of inviting, Dr. Epie Njume. Just as he comes on, let me invite you to put your questions in the Q&A box at the bottom of your screen. We'll be picking those towards the end, but at any time, you are welcome to add in your questions or your comments into the Q&A box at the bottom of your screen. Epie Njume, over to you.
Thank you very much, Folake. Greetings, everyone. I'm very excited to participate in this webinar series and to share CBC Health Services experience in delivering integrated services in humanitarian settings in Cameroon. So the CBC Health Services is the second largest provider of health care in Cameroon, only after government, and we have extensive presence in very remote communities, and most times CBCHS is the only partner providing health and development services. We are present in over 9 of the 10 regions in Cameroon, but especially in the northwest and southwest, which you can see on the map on your right of this, on the right of the screen, northwest and southwest, circled with the red circles, and we also have presence in the far north of the country. But this map essentially also describes the different humanitarian clusters, and CBC Health Services has presence in these places. But our focus is mostly in the northwest and southwest that has been experiencing armed socio-political crises in the past decade, pitting non-state armed groups, secessionist groups that are fighting against government security forces in a kind of guerrilla type warfare where unknown armed groups frequently come out of hiding and attack government positions, and then there are retaliatory attacks from government forces, and the population is caught in the middle. And as such, there have been loss of life, loss of property, destruction of key infrastructures, including health facilities, and there is a disruption in supply and supply chains, and even cold chain systems for immunization. And so the CBC Health Services being in these places for over 7 decades and building trust is a very key stakeholder, because they are accepted by both sides as a neutral partner. And so that's why we've been able to deliver services to the last mile in these communities. Next slide, please. So our approach in terms of program rollout starts with an assessment of the barriers within a community, which enables us to identify community needs. So we don't use a one-size-fits-all approach. We ensure that we start by assessing the needs in each community, as well as identify key stakeholders and other community systems that we can leverage, especially in securing safe humanitarian access, because there are some communities that are completely controlled by non-state armed groups, and entry into these communities must only be done after the after securing safe humanitarian access. And in terms of service delivery, we are providing an integrated package where in addition to immunization, we have nutrition services, JBV identification and referrals, vitamin A supplementation, deworming and malaria prevention kits, wash kits as well. And we have intentionally designed our programming to be adaptive because our environment is very dynamic. And so our programming responds to each of these changes as they happen. So on the graph on the bottom of the screen, we're trying to show the number of pentadoses that we've administered throughout our programming from 2023 through to 2025. But the most of the integration has taken place between March and December of 2025. And as you can see, the overall number of children vaccinated, even in these communities, is higher compared to previously when we were not intentionally integrating vaccination and other humanitarian services. Next slide, please. As far as integration goes, we started by training all our staff on the basic humanitarian principles and then additional principles, and later sought partnerships because even though as CBC, our funding extended to bringing immunization to the last mile, we needed to integrate immunization in these services. And so we sought partners who could provide additional items that constitute the integration package. So within CBC Health Services itself, we collaborate with the humanitarian response team that is playing a key role in nutrition services, wash services, and also distribution of dignity kits and other items in the package. And through Well Food Program, we've been able to get the different food supplements that are part of the nutrition service. And through the socioeconomic empowerment of persons with disabilities program, which is a development program within CBC, we are able to identify children with disabilities and refer them to colleagues who can now attend to them with the needed support. And Alima and IMC providing healthcare services in some of the focus areas we work in, but mostly at the level of the health facility. And so being in the community, when we identify cases that require medical attention, we refer them to the health facilities that Alima and IMC support. We also collaborate with local civil society organizations that are playing a key role in engaging communities, in identifying zero-dose children, zero-dose and under-immunized children, and linking them up to care. Next slide, please.
There you
Yeah,
go.
as far as okay, thank you. So taking a deep dive into integrating nutrition into the vaccination or immunization activities, we always start by mobilizing the additional items. So in this case, we mobilize the supplementary foods, and most of it is coming from World Food Program. And then we've trained our staff to conduct basic rapid nutrition assessments, which is done during a vaccination session. So it's in a typical vaccination session, we'll have the vaccinators or other members of the vaccination team for conducting a rapid nutrition assessment, including observation and measurement of mid upper arm circumferences using the MWAC tape. And children with moderate acute malnutrition are provided supplements, and those whom we identify with severe acute malnutrition are referred to the closest health facility. And so in the table showing the data, including the number of children screened and immunized, and the number of SAM and MAM cases identified, is very different in each of these places. And this reflects the level of accessibility into these focus areas, the scope of programming so far, and also highlights the availability of partners, because for integration to occur, we must have partners who are available and able to provide the additional services that make up the integration package. Next slide, please. So as we roll out our services, we are also keen to get community feedback, and we included this at the very start of the program during the assessment, trying to get the community's appraisal of vaccination services and whatever services they thought they would need. And so we get all of these quotes that show that whenever we come with more than vaccines, the population is more accepting and more willing to bring their children for vaccination. And so we've also seen that in places where there was hesitancy, or where parents understandably are trying to secure other needs, because these are our target population are living in communities with multiple humanitarian needs. And so most times the parents and guardians would want to try to look for shelter, and then also ensure that the children have food before wondering if they would be vaccinated, especially when the children are healthy. So one of the ways in which we encourage them to get their children vaccinated is to integrate the services so that they get a comprehensive package. Next slide, please. Between March and December of 2025, we vaccinated more than 172,000 children and provided immunization services to more than 70% of this number. And like I mentioned before, the services are not necessarily the same in each vaccination session. In some sessions, we could have vaccination and nutrition services and vitamin A supplementation, deworming medication distribution, and other kits, while in others, sometimes when we do not have the supplements, we still conduct the nutrition assessment, but would also, when available, also distribute insecticide treated bed nets and other items as the case may be, and whichever item is available in the different settings. Next slide, please. So to us, integration is not only a choice of operations as a way of working, but essentially it's the only way that we can meet the needs of our target population within these communities. And we've seen that through the integrated packages, we've been able to prevent malaria. We've been able to improve childhood growth and development through nutrition services, deworming and vitamin A supplementation. And as far as operations itself go, it is the best way in terms of saving costs and security and safety for our teams on the field to work, because we have the same teams who have multiple skills, polyvalent staff, who within a single visit would provide multiple services. And in that way, we limit the number of staff who are exposed to the security risk in these settings. And as a result, we've actually seen that through integration and integrated packages, we've been able to reach many more children. We've been able to continue to boost the trust that we've already gained as CBCHS within these communities, and keep the community engaged and open to many other services beyond immunization. Thank you very much.
Thank you, APA. And at this point, I'd like to invite Peter Mutanda with the IRC REACH program to take us through an overview from their perspective. Thank you very much.
Thank you so much, Dr. Folake, and thank you, APA, for that, and also for the grounding presentation by Stefan. So I want just to take us through REACH. REACH project has been operating for the last 3.5 years, working across 6 countries, across the Horn of Africa. We got 2 other countries joining the consortium last year, in 2025. That was Chad and Nigeria. The REACH design was to deliver immunization services and programming in some of the toughest, hard-to-reach areas, afflicted with conflict for many, many years, neglected by, war, conflict, just utter government neglect. So the zoning of the initial design was to look at how do we, ensure that children who have been residing or living in these populations get their vaccinations, or just have the catch-up vaccination, just to ensure that they don't reach the 5-year age before they get their optimized immunization schedules. So it was so designed in a way that we had to look at very many multifaceted delivery channels, considering the areas of operation, not very far from what Dr. P has been describing, conflict areas, active war areas. We had to look at what could be changed in terms of moving from the conventional service delivery approaches to kind of being specific to context that we were alive to at that particular moment. We had to look at areas of capacity strengthening, getting staff in some of the areas that had not had vaccination, being offered for close to 3 years, up to 5 years in some of the regions. We've broken down supply chain systems within our cold chain system in some of the areas. We had to procure some of this in some of the select particular zones that were completely cut off from the normal channels of distribution. And the whole logistics of vaccine cold chain management was quite massive, I could say, in the early year of the project, for the sense that in some areas we are almost starting a whole new project, from setting up the system at that micro level to ensuring that service delivery resumes with the minimum interruptions in terms of operational attributes. Next slide. Progressively, we've had quite very good outputs from way back in 2022, when we had just a sprinkle of locations that were accessible. We had a target of about close to more than 150 locations that were earmarked for access. But again, it took a little bit of time for us to achieve that number. But I think we could say that by the end of 2024 is when we were really benefiting from the efforts towards ensuring that we have a supporting structure to provide immunization to the older children. A lot of the policies were not supporting that age cohort, despite the talk of the big catch-up that was being discussed across all the regions. But we knew that it was a little bit of a problem to transfer the policy to implementation, for the fact that there was a behavior that had been created in the system for a long time. People are used to not vaccinating older children. After 1 year, maximum 18 months, then the others are just booster and intensified the program vaccination activities. But I think we went ahead to look at what could work, and working a lot with the local partners, national partners who are quite influential in the delivery of this project. As you can see, in the year 2025 alone, we delivered close to 20 million doses across the 6 countries. And as you can see, the older cohort progressively, it was getting a bigger proportion of access, using Pentawar or DPT1 as the benchmark here for access for the first immunization. In some areas, I think it was a little bit different between a proportion of, some areas was close to 50-50 proportion, others were around 70-30, but you could range it between 55 and 45, 45 being the zero dose children in the community, and the 55 being the routine Penta 1 being given to children below 1 year. Next slide. So not very far off from the CBCHS situation. So the biggest thing and investment in the REACH project was humanitarian access, because it was almost starting from a blank template, for the sense that you knew there's an area that is isolated from the normal support, but you had to negotiate access to those particular regions. So that meant being tactical, using your own organizational ways of approaching humanitarian impediments, particularly where we had barricades, barriers, active war, where you had very limited times to get into a situation and offer services, a very small window that you are given to access a community and then get out as soon as that was possible. We also had to look at other ways of generating demand and also engaging the community. Of course, just mixing the conventional ways of demand creation, but also going a little bit higher in terms of the direct small group engagements and also targeted, influencers in the community. Influencers here would mean that, of course, the usual gatekeepers, the community leaders, but again, many times will be some of these, authorities that control some of these conflict areas. In terms of data management, again, we did not have a straightforward system across many of the countries in terms of just ensuring that we have the data that can capture zero-dose children into the system. So we had also to improvise in some situation where you had some other channels of records, service delivery records, so that we can capture that information before the full rollout of the revised tools was done, maybe towards the end of 2024 and also early 2025. And of course, the challenge was always that in some of the areas where you are never sure that you are going to stay for a longer time, ensuring that how long can we sustain a vaccination for those communities until we achieve full vaccination for the children through that period of time. Yeah. Next slide, please. Yeah, I think the rationale here is not completely out of what has been said before, first by Stefan and Dr. Pierre, is that integration wasn't a thought after, approach. It was part of the design of the project, in the sense that we knew without integration we will not achieve much based on documented benefits, in terms of just promoting efficiency, best use of resources available to us, understanding the limitations that we had, and also being a very quite costly, venture. It takes quite a lot of resources to hire vehicles, hire security, travel long distances in a place where even getting fuel can be a problem. We've had places where we had 2 months without fuel for vehicles. People have to wait until you get supplies come through some very difficult channels. Just enabling that service provision to continue in those underserved areas was very, very important that we integrate, because we had other elements of PHC that were being undertaken by partners and also by IRC through other programming. So we feel integration wasn't like a learning. It is something that it's a programmatic imperative. It is expected that if you are handling such kind of a program, you need to look for opportunities where you can maximize and optimize the use of other resources. And we also like that many of our partners, we worked with them, close to 16 partners spread across the countries, had other channels of funding mechanisms. So that made it a little bit easier to embed a rich project into other lines of programming. The next slide. Yeah, so we mapped out a line list of possible services, but mainly the PHC elements, nutrition, just IMSCI where that was possible, screening, distribution of some of the commodities like malaria nets, and many of these channels of support were coming outside what Rich was providing as a funding portfolio. So it was important that we also negotiate with some of the implementing partners, not our partners, but some of the partners that were able to access some of those areas to align our services and work with them. And I think it was a beneficial element to, it was a win-win for all of us, for the sense that you could have a co-planning activity while a team is, conducting an assessment on, availability of, mosquito nets. At the same time, they'll be screening for a zero dose, mapping out communities for zero dose children. Then you will combine some of the services together. Although it wasn't possible because of the project lifelines. Some projects are very, very short, 3 months, 6 months, while you have maybe 1 year project. So it was a little bit intricate to balance where we'll start integration and where you will stop the integration. So, but the main aim was just to ensure that the leverage for presence and available resources is to integrate was maximized at every given opportunity. While it was not longitudinal across all integration, but it was quite helpful for a considerable amount of time to ensure that we reach a maximum number of children and communities with variable services provided at the same time. Next slide. Next slide. Yeah, so I think Dr. Pierre spoke about this a bit in terms of what do you consider when integrating. Of course, you need to consider it at the beginning of the program, at the beginning of the project. It cannot be an afterthought. What services are available to you? How can you map out this? Are they able to meet the demand, the service demand? What is the capacity available in the system? Do you need to train more people? Is it going to have a burden already, fragile PHC systems that, are almost struggling every time? Again, the bit about acceptance, we didn't have a lot of problem with acceptance of vaccination in many of the areas, very, very few places, as maybe Dr. Moon will speak to in South Sudan. But the buy-in wasn't a problem from the communities, but again, just the acceptance that we are providing these services from suspicions about you coming from the other side of, a conflicted area or an opposition area. So those levels of just being sensitive to the community's, perception around where these services are coming from. Are they coming from a place where we feel they're hostile to us? Can we trust them? So those were things that were really happening and were quite live to understanding that it was not easy just to go in and provide services. Target setting was a big thing because we didn't have quite reliable data across the regions. So it was a lot of triangulation across, trying to see if we can get to the right targets. We kept on improving every year, realizing some areas maybe we over-targeted or under-targeted, getting it right the following year, and just aligning this to what we know in other places. But this is an area that we learned quite a lot along the service planning for REACH project. Again, much as the REACH project was not a system support program, but it was difficult to avoid the system management elements. Like you could get a district, a jurisdiction that have nothing around cold chain system, and you have to set it up. Working with the local authority, set it up from scratch, organize teams, ensure that the system is maintained, have the right capacity, ensure the channels of commodity management and supply are well maintained. So it was a lot of coordination and then reporting and learning and ensuring that there's enough collaboration with the local partners and also the government and the donors. But I think one thing that we need also to be cautious about is about integration is good. I think we've been integrating services all through for many, many years, for decades. But when you are in the field of implementation, you start realizing that sometimes it can be a burden. And if you're adding layers and layers and layers of services to a single stream of, a capacity chain, then something will drop off. If you have nutrition screening, you're distributing nets, you're providing nutrition services, you're conducting IMNCI, I'm not sure you're going to do that in a very, in a quality way. So that's an area that I think every implementer has to be wary of, that when do we stop? When do we say that this is now over integration, if there's such a word? When do we say this is too much? Yeah.
Peter, thank you
yes.
so much. I think you've done a fantastic job summarizing some of the key lessons across the 6 countries, and absolutely very, very, very important lessons that you've highlighted here. I'm going to ask you to let's go on with Dr. Muni Safi, because he's going to take a lot of the lessons that you have highlighted into the deep dive on South Sudan. So let me invite Dr. Muni Safi, who is the REACH project coordinator in South Sudan. Once again, let me invite you to place your questions or comments in the question and answer box at the bottom of your screen. Muni, over to you.
Yes, thank you so much, Dr. Fulaki. And good morning, good afternoon, good evening, everyone. Greetings from South Sudan. And thanks to the previous presenters, Peter, Dr. Pio, and Stefan, for setting the ground. They have actually made my work a bit easy. So coming to South Sudan specifics, on the ZIP or the REACH initiative, the REACH project in South Sudan is being implemented through a consortium of partners under the leadership of IRC as the lead partner. So we have 4 partners and 2 national organizations, and we are leveraging on the abilities of the national partner to be able to navigate the local context for access. And also, let's not forget that we also receive support from our global partner, that is Think Place, who help supported us with the development of the human-centered design with the different prototypes they were developed in for demand creation and community engagement. And as well as Soflo Mayenda, who supported us with the digitalization of the micro planning. So it is being implemented in 5 states and 1 administrative area across 15 counties, and it's 38 PAYAMs, focusing on the special communities, the nomadic, the cross-border, the IDPs, and the returnees. So the map there depicts the geographical focus of the project with the different colors with respect to the various organizations. So, yeah, next slide, please. Yeah. So why are these focus areas ZIP? One of these areas, one of the reason is that these are areas with the uh, high population with high burden of zero dose children and under immunized children, and this has been done collaboratively with the Ministry of Health in identifying these locations. The other component is around the humanitarian context. These areas have quite significant access barriers, and they are highly fragile and conflict affected with difficult terrain uh, as a result of climatic shocks. And the other component, of course, is the issue around the limited services in the hard to reach area where the national immunization program cannot reach. That map showing the Penta 1 doses delivered across the 3.5 over 3 years. And basically, it shows the story or the journey from 2022 at the point of inception in December through to 2025. And you can see progressively the outputs have been progressively improving as a result of investment that has been made along the way. In particular, 2023, a lot of work has been made around the demand generation and community engagement, the development of the different prototypes of mother-to-mother support groups, and um, the community dialogues, the integration, among others. This has been very, very effective in addressing some of the key barriers. And as well as so, we had the work around the digitalization of the micro planning, which helps in tracking the population and also help in mapping the social pattern. And then, of course, 2024 is the year where we saw a bit of deepening, program deepening, where the different contextual strategies are picked up, and also many of the innovations which were done in 2023 had taken shape, and 2025 also we had much better performance as a result of some innovation, including the introduction, including the some catch-up plans, catch-up vaccinations to be able to reach more children. Next slide, please. So when we come into the activity that's been integrated, we are looking at the wider component of the primary healthcare services around outpatient consultations, antenatal care, uh, reproductive health services alongside curative. But what is most important here is that integrated immunization service with the CMAM, that is the nutrition the component, special screening has proved to be very, very key, and in terms of impact and scale, in special outreaches, planning integrated outreaches. And one thing we need to know, this integration mostly is partner-led, which has been done through the partners come together, they map up resources, they have joint planning and monitoring and support supervision, and this mostly targeting the remote areas. Some of the areas are as far as 40 kilometers away, and this has been able to bring comprehensive services to the hard to reach locations across the country. Next slide, please. So this slide basically here is to demonstrate the impact of integration. This is that we just pick one of our focus area and track the data, and it is so that when you integrate immunization service with the other services within primary health care, and most important integration with the primary health with the nutrition services, we are able to reach more numbers of children. We are able to have more impact. So it is critical that we immunization services are integrated with the nutrition to be able to increase the uptake of services. Next slide. Yeah, I think probably this is one of the most important slide. And this has been also discussed with, by the previous speakers. Why do we integrate? We one you know one of it is to be in terms of responsiveness, and then here we are looking at being able to provide comprehensive services in those hard to reach areas, and this will reduce missed opportunity for immunization as well as providing other services alongside immunization. Because most often, if you go to these far to reach areas and data services are not there, you find the community, asking for other services other than immunization. And also, it builds trust from the community, with the community. And then the other reason is, of course, resource optimization, best use of resources, which lead to efficiency and of the services, because we are able to reduce some of the cost as we are because as we are they are integrated together to be able to reach the special community or the mixed community. And overall, of course, in terms of uptake, we have seen improved uptakes across the focus areas in terms when the services are integrated together, immunization service integrated with the nutrition, integrated with the was integrated within the other component of the primary health care. This has led to, because most often beneficiaries they might come for other services other than immunization, but in the process they end up getting also immunization services. So that is really very critical. And of course, the other component, of course, overall health outcomes improve because they are provided with a number of services, not only immunization, they also get other needs which they have, and this also builds community trust with the beneficiaries. Next slide, please. Yeah, for this is just reinforcing the previous component that's saying that integrate, especially the outreaches, the community-based outreaches sessions are very critical, that we are able to bring services closer to the mixed community in hard-to-reach locations, and this has promoted, increased uptake of services. Of course, community engagement and health services integrated during outreach lead to improved community in terms of awareness and also in terms of reducing vaccine hesitancy, as we address some of the key misconception or the myth around vaccination. And so of course, one of the reasons why sometimes people don't come for this service is because of the long distance. Distance about 40 kilometers, and therefore, when you have a integrated package and you take this service closer to the communities, and therefore you help support them in terms of reducing the distance and providing access to immunization as well as other services. And of course, one with regard to integration, one of the things has been that it has been a bit difficult, or we to measure or the cost effectiveness of a fully immunized child. And also, what we have not known is the number of children that will have reached that will have missed immunization with that integration. So there's still a lot of work to be done around integration. Yeah. Next slide, please. Now, around the challenges, we still have issues of comprehensive data for integration. The data integration is not yet being properly. There's not enough data for us to generate enough evidence so that this, as part of the routine, maybe support supervision, the tracking of the data. So the data tools needs also to be worked on, and a number of things. So I know there's still ongoing discussion also even with the MH to see how this can be improve further to see that we have data showing evidence of integration. And then, of course, the other components, the absence of comprehensive services in some of these remote areas. So they still need to see that services are taken to this area. So there's that challenge of some areas they don't have comprehensive services; they have a limited range of services. And then, of course, just like Peter later on discussed, the vertical programming and then the funding mechanism. We find a funding comes specifically for immunization and therefore responding to the other needs. Maybe if it is SRH, if it is WARS, it becomes a bit challenging. So there's still room, there's still that challenge around the vertical programming, which comes specifically for specific project with specific targets and goals. In terms of opportunity, yes, we are saying at the donor level, we need to foster donor mechanisms that that encourage or that strengthen integration, so that this is done at the proposal or at the project design level to be able to support integration better. And of course, also strengthen partnership with the Ministry of Health, the health and nutrition partners, to keep, improving the integration approaches in terms of also being a part of the routine supportive supervision, to be able to be tracked that yes, we are doing integration and there's evidence that data is being tracked. And finally, around the lessons learned, I think Peter had also earlier talked about this. It's always good to have this integration at the proposal stage and as a project design phase, so that this is better incorporated into the design and be able to factor in the different components of what is required for a better integration service. And then, of course, like integration should be part of the routine data collection and keep performing. There should be some key performance indicator that are tracked to show evidence of integration. That's some learning there. And then finally, we need to be cautious as much as we want to say we want to integrate. We need to speak okay so that we don't overdo it and risk or compromise the quality of care, because with integration the lot comes into play. We need to ensure that the staff are well trained. They are not there's no burnout, which will lead to compromise the quality of care and therefore lead to reduced quality of services. Next. Yeah, so that marks the end of my presentation. Thank you. Over to you, Dr. Fleki.
Moni, thank you so much for taking us right to the front lines in South Sudan. You've really highlighted some critical issues, lessons, as well as good practices that you are seeing. I want to really appreciate all our speakers and our audience today, because I can see a lot of really great comments in the chat. We're going to go to questions and answers now. But before we do that, there's a quick poll. Again, this is just to warm us up. On your screen, if you can take 30 seconds to respond to the poll that we have here. What services do you think should be integrated with immunization? Select 2. Quel service devrait être intégré à la vaccination? Sélectionnez 2. So we're giving you 10 more seconds. Okay. Let's go on to see what you have put here. Oh, this is very interesting. Thank you for all the responses. I can see right at the top, nutrition. Nutrition seems to be a natural integration point, particularly looking at the age group, and that for immunization and for key nutrition and interventions. I can see another one here, which is child health services, including vitamin A, deworming. So that's another very, very good one. I can see, interestingly, at 26%, we have food distribution. And I see in the chat a few other ones coming up, such as WASH, nutrition screening. Thank you. Please keep it coming. I think these are excellent examples. Malaria prevention, as well as sexual reproductive health. I think for me, the key takeaway here is that the target population, particularly looking at the infant or the child and the mother. So services that can really target both the mother and the child, I think are really important for opportunities for integration. I'm going to close this out. Thank you very much. And Desiree, I like your point here in terms all have potential, but depending on the context. And we heard from the presentation today that integration was different based on the context and availability of other services and commodities. Now, we are going to take your questions. And a number of them have been coming in, so thank you. Right now, the one that I'm going to start with, this is really looking at a question that has really come up in terms of negotiating access. And so maybe this will go to EPA and maybe EPA, Peter, and Muni, you can speak to this really quickly in terms of what has worked well in negotiating access to communities to deliver integrated services, and what are some of the lessons learned. EPA, do you want to start briefly, and then we'll just take a quick tour with Peter and Muni.
Okay, thank you very much, Folake, for the question. This is very crucial because we work in communities that are undergoing active conflict. And so for CBC Health Services, haven't spent so much time within these communities, we've built trust, which helps us to go into the communities and work with key stakeholders. So we identify, as a strategy, we identify leaders within the community. They could be traditional leaders, religious leaders, and other opinion holders. And then through them, we now gain access to safe access. So we as CBC Health Services are unable to, we do not interface with the different parties directly, but we engage the different communities in which we are working to negotiate the access for vaccination teams to freely and safely deliver the services. So for CBC Health Services, I think the most important aspect is the trust that we have built over the years, because the population sees us as being a neutral party in the whole in the conflict. Thank you.
Thank you. Peter, do you want to add to that? Or Muni?
Yeah, sure. Because again, thank you so much. I think again, understanding the community leaders are there. They are usually almost all ground, but just the sensitivity of getting to a place where people have been isolated for a long time was quite an experience for each in many of the areas. Just developing that trust that, are we sure what you're bringing us is right, is correct? Are you sure there's nothing sinister about your services? So I think developing that trust took a little bit more time than what was expected in some of the areas. But again, just maximizing the presence and the strength of our local partners was quite effective and quite strong. In some of the places where we've had to trying to transition out, communities have come and said, no, this partner cannot leave us. We have to find a way of getting them to support us, to continue supporting us. So I think that element of that strong local partnership is quite essential.
Thank you very much. Mooney, I'm going to come back to a different question for you in the interest of time. But there's another question, and this question is really looking at how have you been able to really establish the information and data systems, and what level of granularity do you have to be able to support integration that you are doing? I don't know if Mooney or Epie, you want to speak to this? What's the granularity of the data? How are you establishing those data systems to support integration itself?
Okay, thank you very
Yeah, and
much,
I'll just
Folake.
invite Epie, Peter, Mooney, and Stefan to be on camera for the remaining time. Thank you. I love to see your faces, so it's great. Thank you. Epie, please go ahead.
Yeah, thank you very much. So in terms of granularity of the data, first, we need to all understand within the communities where we work, the data on the target population is very unreliable, because partly because of population displacements, and then in our setting, they are mostly based on estimates and projections that are on real data that was collected more than a decade ago. And so it's very challenging in terms of planning. But what we do is we try to get a very try to make an intelligent guess in terms of estimating the number of the population that we are going to meet in a particular community. And then as far as collecting the data during the services, we are able to collect data on the sex and age group of the children. So we usually split them into 0 to 11, 12 to 23, and 24 to 59 months. So we collect data on the gender and these age groups, and then with the different services, of course, with the antigens that were provided and the particular additional services that we provided during that session. Thank you.
So, Pierre, it's interesting that you highlight sometimes dealing with the impreciseness and bringing a flexible approach to that in terms of the data. So thank you very much for that. There's a question I want to invite Mooney to respond to, and this is really looking at demand generation and community engagement activities. So where these were carried out, what were the unique features around the demand generation and community engagement with an integrated approach? And what were the challenges and benefits of this during an integrated approach?
Yes, thank you, Dr. Falaki, for that question. Yeah, coming to demand generation question, using the human-centered design, which with the integration as one of the prototype. One of the challenges that we face in terms of the vaccine hesitancy, and that is associated with some of the myths around vaccine. So what we did was to, have those community dialogues with the community to be able to give the right information to them, and as well as vaccinate those who have accepted the services during those sessions. So we also capture that data of the children who have been vaccinated during that session. So I will say that understanding their problems, the key barriers, and addressing them was really very, very critical. And what we have also realized that using the community gatekeepers, whether they're religious leaders, whether they are community, whether they are teachers or whatever leaders they are. Normally, when we capacity build them, giving them the right information, and then they become community champions. They are able to, they're able to lead the way, to be able to spearhead some of the messaging during events, and this has also helped support the uptake of the immunization service in some locations. And with that also, I think what we have observed is very critical is that the messages, the tailored communication strategies are also very, very critical. So that there are this message which are also integrated messages which are able to be passed to the community to inform them that we are going to have this kind of array of services, and this has also helped the community build a trust, build that trust. And of course, one thing also is capacity building the staffs. When you give adequate capacity to the staff, they're able to provide quality services. They're able to pass the right information, because we also realize sometimes the problem is not actually with the community. Sometimes the problem is with us, the health workers. So when you give the right capacity to the staff, they know what exactly what to do, and that also build trust between the health workers and the community, and that also has led to increased uptake of this immunization services. Thank you.
Thanks very much. Epie, there was a follow-up question that I want to put to you. And this is, what type of new technologies did you use in terms of helping with that data collection quality gap? Were there any that you can mention that were useful?
Yeah, so thank you. We at the beginning of 2023, we tried to use electronic tools within tablets to collect data on the field, and this would have enabled us to collect very granular data on each child that we immunize. But unfortunately, it wasn't accepted within the communities we work in, because the non-state armed groups thought that the devices could be used to pinpoint their location. So we quickly abandoned the idea, and so we stuck to paper-based tools that we've designed to ensure that, okay, on a one page, the vaccinator is able to collect data on the child, at least the gender and the age group, the particular vaccines provided, and the additional services. So for now, we haven't used any new technologies. Thank you.
Thank you for that insight. Muni, is there anything you wanted to, or Peter, anything you want to add to that in terms of technologies for data collection and quality? Peter?
We had to adapt a lot. We had to adapt a lot. We had to change, not change, but just adapt, bring in some other layers of reporting for us to meet the demands, especially for the reporting for the older cohort of children, because it wasn't possible to get the data out of the service delivery structures using the old tools. So in many countries, you had to print new tools, of course, in collaboration with the authorities, the ministries, and then that had to change in a big way. So Rich, we've used ComCare, from the field. It has worked so well. We had difficulties just in terms of getting the whole scale being operational, but towards the end of 2025, ComCare was very useful in terms of managing our data entry systems. Yeah.
Thank you very much for that, Peter. I do have a question for Stefan. Stefan, I'm sending this your way. And this is a question in terms of how will Gavi ensure that all Gavi-funded partners implemented in humanitarian settings are, in quotes, permitted to do context-appropriate integration. I know that this came out in the presentation today, but just like to hear your thoughts on that.
I think we might have lost Stefan.
Stefan?
We
Okay.
lost Stefan. So I'll have to get back to you on that question. But I think some of the things that Gavi presented earlier on the 6.0 strategy and some of the commitments there give a sense of that. But yeah, he did have to just drop off. Thanks.
Okay. Sorry we missed him, but I think we'll follow up on these questions. So I'm going to have a last quick question here, and this is really looking at the adaptations or adopting the periodic intensification of routinization, long-term, and tracking intervention. So for example, how are you looking at home-based records or other updated facility registers? In the context that you're in, what are the alternative methods that you are using in terms of service delivery and the recording? Peter, do you want to take a stab at that one? Oh, we can't hear you.
Hello?
Yes, we can hear you now.
Sorry, I missed you I missed you for a second there for like.
Okay. Yeah, so the question is really asking about what are other alternative service delivery approaches that you are looking at for the long term, and any recording that could be a bit more consistent in future. And we'll just wrap up on that.
Maybe not in the form of being consistent in the future, but the service delivery models that we used, that we had to use in many of the situations were, quick in, quick out. First time we used to call it, hit and run, but we thought that was not a very good phrase to use for service delivery. And then we changed that to quick in, quick out, in the sense that you negotiate access for a very, very specific period of time. You're allowed to go into a villages, you go in, provide services, you're given time out. You have to go. And then again, have a schedule for the same. So that worked for those difficult to access areas. So I think that's a model that can be used, maybe sustaining it, I don't know, but can be used in situations where it requires that you have to negotiate for just entry, 2-3 hours in a community, go out. But the others, mobile was quite difficult because teams could not spend nights out because of the security reasons, as much as we had what we are calling extended outreaches, going beyond the conventional 5-kilometer, radius that we all know in EPI. People will go to up to 30 kilometers, 41 kilometers, but still come back to the base. Yeah. So that can be very expensive also.
Well, thank you all so much for taking us to the front lines today in terms of the complexity of working in crisis, conflict-affected, and humanitarian settings. You have shared important lessons and insights. In fact, we could not get to all the questions today, but we will follow that up. With these critical insights and practices, I'd like to encourage all of you to continue to engage with this material and share widely. I'll also remind us about the IA 2030, which has really emphasized immunization and primary healthcare integration within different contexts. So let me pass over to Caroline to close us out. Thank you.
Thank you, Dr. Falake, and thank you all of you who have joined us today. On behalf of Core Group, I would like to thank you for being part of today's webinar. We are grateful for the time that you've taken to join us, and we hope that the discussion and the questions offered valuable insights and sparked meaningful reflection. I want to extend Core Group's sincere thanks to our speakers and the moderator for generously sharing their knowledge and perspectives. Your input has been instrumental in deepening our understanding of this critical topic. So I'm going to give a virtual thank you to Dr. Falake Ola Inca, Stefan Dufis, Dr. Epie Njume, Peter Mutanda, and Dr. Muni Safi. Thank you again. The insights and exchanges shared today emphasize the importance and value of integrating immunization for zero-dose children in missed communities with other services such as nutrition. The benefits of doing this include the consideration, safety, and preferences of caregivers, better resource efficiencies, more consolidated measurement opportunities, and ultimately greater immunization coverage and better health for all. We hope today's webinar motivates you to further continue this discussion and to advance the integration of immunization with other essential services. We look forward to welcoming you again and encourage you to stay engaged. The presentation recording from today's session will be shared soon via email. Thank you once again for your participation. We wish you continued success, and we hope to reconnect with all of you in our next session. Thank you and goodbye.
Thank you all for your time.
Thank you very much.
Thank you
Bye-bye.
Thank
all.
you.
Bye bye.